I've been given the thumbs up, so good day, and welcome to this Waterloo Smarter Health Seminar. I'm Shirley Fenton, Managing Director of the Waterloo Institute for Health Informatics Research. Thank you for joining us today for our third seminar in the series entitled The Many Facets and Facets in Health Informatics. I'd like to welcome our web viewers and Ontario Telehealth Network sites. This seminar is being recorded and is being broadcast over the web. We ask that you hold your questions to after the seminar presentation so that we can get a real or virtual mic to you. A very warm welcome to our guest speakers, Mr. Tom Vare, Executive Director of the Sault Ste. Marie Innovation Centre, and Michelle Corneen, Health Informatics Development Officer at the Centre. We'll have the introduction of Tom and Michelle in just a minute. I'd like to acknowledge our seminar series sponsors. As you see on the slide, they are Borden, Ladner, Gervais, McKesson, and Healthcare Information Management and Communications Canada. Without these hosts, we could not hold these seminars without their support, and we're very grateful for that support. Before I begin, I'd like to make a couple of announcements. Our next Health Informatics Boot Camp will be held June 18th to the 20th. There are still a few spots. There are some flyers at the back or at the registration desk if you're interested in attending. It's a great event, a packed full 2.5 days, and you learn the core broad comprehensive overview of health informatics. In addition, our next seminar in this series will be given by Dr. Danny Sands. Again, there's a flyer about this seminar. The title of his talk will be Illness in the Age of E, How Connected Technology Changes the Patient Experience. So Dr. Danny Sands is the Senior Medical Informatics Director of Cisco Systems, as well as Assistant Clinical Professor of Medicine at Harvard Medical School. So that will be a great talk. The third thing I would like to mention is that in our research seminar series, the next seminar will be given by Professor Sen at the University of Waterloo, and he will be talking about cigarette taxes and birth outcomes, empirical evidence for Canada. So if you have the opportunity, I encourage you to attend any of these events and come to the boot camp if you can as well. As I indicated, this seminar series looks at the many different facets of health informatics and some of the key people involved in these areas. So we've had people talk about personalized medicine, health informatics as critical support for clinical research, medical imaging, just to name a few. Our agenda today is as follows. Professor Dominic Covey, who is the founding director of the Waterloo Institute for Health Informatics Research, will introduce our speakers. Tom and Michelle will speak for about 45 or 50 minutes. After this, we'll have a facilitated discussion. And as I said, we ask you to hold your questions to after their presentation. Just please signal to either Dominic or myself that you have a question, and we'll get a microphone to you so that that can be incorporated on the video recording. We also welcome questions from our web and teleconference viewers, so just please send in your questions and we'll try to get them incorporated into the discussion as well. So may I introduce to you now Dominic Covey, who will introduce our speakers.
Well, welcome. I'm glad you were able to make it here today. I first met you, I guess, about 2 years ago. I'm not sure exactly when or where. And we started talking with Tom and the people at Sault Ste. Marie. If you're not aware of it, the Group Health Organization, Group Health Centre, I believe it's called, in Sault Ste. Marie, has been one of the most innovative centers related to the introduction of a variety of technologies into health. Did early work on smart cards. They were one of the test sites for the concept of capitated care in the province. A lot has been learned in Sault Ste. Marie. I always claimed it was because they could fail up there and nobody would notice. But interestingly, it built a real culture of innovation. The Group Health Centre is now one of the most comprehensively electronically supported health organizations in the province, very advanced work, and recently received an InfoWay Infoway support for some work. Perhaps you'll talk about that a bit, Tom. So what we're dealing with here is a very tight community located kind of far away from us, but which has actually made a real difference in primary care. More recently, we've been in discussions over the last at least year and a half about creating a center or an institute for primary care informatics together with Sault Ste. Marie, which is still in the developmental phases, and hopefully will move forward. That includes some significant industry support for that activity. So, little known to people, this has emerged as being a center that we need to know about. We're very glad to have Tom and Michelle here today. They've been here, at least Tom was here before, and we've met with them and gotten some very interesting interactions going. So it's proving to be a very productive relationship for the Institute. On a couple of points, just for the people who haven't had a chance to see the flyer, Tom is the Sault Ste. Marie Innovation Center's Executive Director. It's a not-for-profit organization that promotes economic diversification through information technologies and knowledge-based industries. He's an experienced high-tech professional. He has an MBA from McMaster University and a Bachelor of Arts from the University of Western Ontario. He's a past member of the Ontario Research and Innovation Council. And if you look at various presentations that are made across the province, you'll see his name quite frequently. I see you're talking in Toronto next month, is it? In June, yeah, related to IT and healthcare. And so they get around. I claim it so they can get a trip out of Sault Ste. Marie regularly. So you can think whatever you'd like. Michelle Cornine, I've known Michelle a shorter length of time, but I've had some very interesting discussions over that time. She is the Innovation Center's Health Informatics Development Manager. She develops and manages strategic projects, fosters partnerships, and undertakes feasibility study in the health informatics sector. Michelle holds an honors bachelor's in psychology from the University of Windsor and a bachelor in information technology from Algoma University College. So we're very glad to have you here today. The way this talk happened was I saw a portion of the slides from this talk in a presentation, and I think it was in Sault Ste. Marie, was it over the internet? I was blown away by it. I thought it was a very, very important example of how GIS could be useful, particularly in the area of public health. So I'm hoping that you'll be as impressed as I was. Welcome. Looking forward to your talk.
Well, good afternoon, everyone, and thanks for having us here. We had to be reluctantly dragged out of Sault Ste. Marie to come visit, but we feel we have to do this every now and then to enlighten some of our Southern Ontario colleagues. As Dominic mentioned, my name is Tom Bear. I'm the Executive Director of the Sault Ste. Marie Innovation Centre. And our organization is a nonprofit organization, Dominic mentioned that, and our mandate is to be a catalyst for growth in the IT sector. So it started in the 2000 timeframe when the community was looking to really diversify the economy. And we focus on three main areas. One, we operate a business incubator on the campus of Algoma University, and the first reading of the legislation went through on Monday for Algoma University to be an independent university. So they're quite excited about that. We also provide support services to our SME, small to medium-sized enterprises, and we undertake some specific market development projects. And that's really where our work in GIS started. It was our first market development project, started in 2000. And I'm going to get into that in more detail in just a moment. I wanted to mention another market development project, and that's really when we sit back and look at the community and the strengths we have, what areas can we focus on for success? And as Dominic mentioned, with the Group Health Centre in Sault Ste. Marie, the organization was started in the 60s, but really is a model for the family health teams today. They have 60 physicians that are associated with that center. They implemented their electronic medical record over 10 years ago. They've completed a Canada Health Infoway project called EMR Extra, which actually tied in the community pharmacists to the electronic medical record. And when Tony Clement was up, he talked about this being the holy grail of healthcare IT. And they're also doing some very innovative work with patient portals, and they've developed a vascular intervention program. And so they've done a lot of really innovative things, and we have a number of other organizations in the community working in some innovative areas of healthcare. So we wanted to foster that. And so we hired Michelle to help us do that, and she's assembled a great group of stakeholders in the community to help drive this initiative forward. So back to GIS. What we thought we'd do today was just provide you a little background on the Community Geomatics Centre, give you some examples of current health and human services work, and then talk a bit about some of the benefits that we've seen and some of the future opportunities that exist for GIS in this area. So as I mentioned, one of our first projects as an innovation center, this was before I joined the organization in 2000, was to set up a GIS department. Both our municipality and our Public Utilities Commission was both looking at implementing a GIS system. And the Innovation Center got involved and said, rather than having two different platforms and two different technologies potentially and two different databases, let's pull these together and let's train a group of local people to operate this GIS system for the municipality and the Public Utilities Commission. And so, to their credit, the leaders of the organizations bought into this, and they established this GIS department, and from that, the Community Geomatics Centre was born. And so, from the first stages in 2000, really at a municipal level, providing services, the Community Geomatics Centre has grown to service over 50 different organizations across Ontario, doing some really leading-edge work in the field of health and human services and GIS. And so we're going to get into more of that in just a moment. Some of the awards and publications, the group, I think, from the early days when they implemented the community municipal GIS application, was recognized as having one of the most comprehensive GIS systems in Ontario. And that's progressed through the years with a number of awards, a number of publications. And last year, one we were particularly proud of is being recognized by ESRI or ESRI at their international conference with a Special Achievement in GIS Award for our work in the health and human services field. So our group got to go down to San Diego and accept that award. So how many people are familiar with GIS in the audience? Okay, so everybody's got a good understanding. I will quickly go through this. When we talk about our municipal system, and this is talking about health informatics, so I wanted to just give you a little bit of the base of what kind of led to our health informatics system. So in our municipal GIS, we have the land-based model, everything out there, the trees, the water, all the parcels and addresses are maintained in that information, the official plan for the community, administrative limits, zoning, all the buildings are digitized, all the transportation, every street sign, every parking meter is maintained within our GIS system. The water model is all captured in the GIS system, and this is all intelligently built so that if something was to enter into the water system at a certain point, you could use the GIS to determine where it flows, what you would need to stop in order to stop this foreign entity from being spread around in the water system. Same thing with the wastewater model. We've got our electric model. All the utility infrastructure is in the GIS database. This is probably one of the most comprehensive data models we have. There's over 10,000 different rules. Again, it's all intelligently modeled. There's pictures of every transformer that are in the database with the manual attached to it. All this information is maintained and stored within our GIS system that our group operates. So it's become very comprehensive for the community. We act as kind of a central repository of community information. So the addressing information is no more than 30 days out of date. We provide that information to city, police, and fire services. And so a lot of the work now is being coordinated. And it's really become, we had someone up from the Canada Urban Institute, and he talked about what we've got really is their vision of a community information utility. And we're starting to see that take place in Sault Ste. Marie through our Community Geomatics Centre. And now we're expanding. We're doing more work in the district, and we've partnered with other municipalities outside Sault Ste. Marie to implement similar systems. So moving into the health world and why we're here today, the Community Geomatics Centre has helped to provide a valuable tool, and really started as we started to do some presentations around the community about what the GIS system is and what we've got and why we're winning these awards. Lights went off in a number of people's heads in terms of maybe we could use this system in our world of health. And so it's provided a valuable tool for these people to better visualize their data, understand the community, and conduct research, and also optimize their service delivery. Our staff, we don't have any researchers or epidemiologists on staff yet, and certainly we just provide really the tool set for these people to visualize their data. All the data I wanted to say in this slideshow has been approved for a public presentation, and we work closely with each of these organizations, obviously in the health world, to make sure that we are ensuring their privacy standards are maintained. Within the GIS system, there's a security module, and we can lock down the information that any particular user has to the attribute level based on who they are. That being said, what we've seen is there's been a great deal of information, anonymized information, that has been able to be shared amongst different health organizations, which has provided a new platform for them to collaborate together and learn more about our community. So it's been a really fascinating implementation, I think, and it's just getting going. As you'll see, there's a tremendous amount of work that can be done in the future in this area. So one of the first examples, and a very simple one, that I think started the ball rolling with our GIS group was someone in the city came to us and said, we've got $15,000 a year to ramp sidewalks. Instead of the abrupt curb drop, we can ramp these for wheelchairs. Where should we spend our money in the community? And so our group went and gathered information in terms of where all the seniors' businesses, where are the hospitals and clinics, where are the pharmacies, where are the retirement and nursing homes. We had information from the Parabus on their pickup locations. And then we could put that in combination to the demographic information of where the seniors are most predominantly living in our community, put that all into the GIS, and we're able to tell them, here's your priority areas to do that project. And so that led us to think of a number of different applications in the health world. And so what we did as well, being a smaller community, we don't have a lot of, or we needed basically 6-digit postal codes for our community. You can't just do, we have P6A, P6B essentially for our community. So in order to do some of this work, we needed the full 6-digit postal code. So our group spent a lot of time and put together that map of the community for 6-digit postal codes. Most of the data that you're going to be, or the maps you're going to be seeing today are really driven by the data that we receive, which is in postal code format. And there's a number of ways you can ensure that, there's at least 5 instances in any one postal code, or the GIS will combine them to ensure that you're not going to ever display personally identifiable information. But most of the data we get is at the postal code level. And so each of the points represents the geographic center of that postal code. Now, one example that we often give in terms of visualizing data is one of the people that actually worked with us was a data analysis coordinator with Care Algoma. And she had to look at this spreadsheet, and it was 4,000 columns wide and 6,000 columns or rows long, and try and make sense of what's the state of early childhood development in Sault Ste. Marie. And so it was a really difficult task, obviously. And so what we did was we started to plot some information for her in the GIS. So this is a simple example of the ISCIS data, which is the birth data by postal code. And so we plotted all the births in the community from 2000 to 2006. And then you could take a look at where the daycares were in the community. Are there any holes or areas that need more services? And the home care locations as well, to look at any gaps in the community in that area as they try and develop new services and roll out new services in the community for children. And then we were also able to do things like do a density map for her so she could look at, where are more of the children being born. Now, each project we do, that usually leads to more ideas on what data could be used and further questions and research that could be conducted. And so they plotted low birth weight babies in the community by different year. And we're able to take that and put that into a density map as well. And then you could do things like taking out the number of births so that you could look at, are there any areas in the community independent of birth density that may have anonymous or anomalous amounts of high low birth weight babies or instances of low birth weight babies. We also looked at the prenatal smoking habit. So women who identified as smoking during pregnancy, that data could be input in the system. And so then you could also look at prenatal smoking habit versus low birth weight baby locations. And then again, do another look at, taking concentration of prenatal smoking habit independent of birth density out, are there any neighborhoods? And so now the public health people are actually going into certain neighborhoods to conduct more education and awareness programs about the dangers of smoking while being pregnant. So it gives you an example of some of the ways that GIS technology can be used in this area. This is another example. Again, we've started doing a lot of work with early childhood development agencies in Sault Ste. Marie. And again, it was really a great experience to see, Children's Aid, Care Algoma, the District Social Services Administration Board coming together to talk about problems and better understand the community. And GIS provided them this platform. And some of them said, boy, we've never been able get this data, or we've never been able to collaborate in this way before, but for whatever reason, the GIS project enabled them to do that. So this is an example of early development indicator scores as children enter kindergarten. The teachers fill out a form based on 5 domains, and certainly there's a lot of work that's being done now on early childhood development and the indicators, and how some effort at that age to ensure that they have the proper skills or the proper training, the proper environment to grow can certainly help them develop in the long run. And so this one is an example. The other one was low neighborhoods, but also you can look at the flip. So are there neighborhoods that the children are doing very well in? And perhaps can we look at any programs or facilities that are in these neighborhoods that are contributing to these great scores for the early domain indicators? We've done maps related to the EQAO test results for grade 3 students in mathematics, reading and writing. This is an example of looking at the visits to our early years center that was actually contained in our main mall in Sault Ste. Marie. And although the rent is much higher in this location, what they found is by having it in the mall, it actually helped to increase the participation rates and the drop-in rates for children and take advantage of the programs offered through this early years center, both for the children and for the parents. This is an example of hub locations for after-school care programs. So again, we started to drill in more detail and gather more information about the community and look at areas of need. This example talks about children. This was an enrollment projection for our Huron-Superior Catholic District School Board, who was really struggling with what their enrollments would be. And in fact, what the study showed was that within the school zone, only 50% of the children that were born in that area were attending the school in their zone. A lot of people go based on maybe where their aftercare babysitting is, maybe grandparents in the neighborhood, whatever. And so it was becoming increasingly difficult for them to predict how many students were going to be enrolling in these schools in each grade. But using GIS, we're able to provide more insight and clarity into that. Outside of early childhood education, we also did a number of projects with Algoma Public Health and our Public Health Unit. So they have a program looking at schools that are close to tobacco sellers or retailers. And they actually visit and they kind of do sting operations to see if they're selling cigarettes to minors. And if you're in a school zone or close to a school, you're visited more often in these programs. So we did a map to show any schools that had a tobacco retailer within a certain buffer period. I think it's 250 meters there for Algoma Public Health. Now, often these projects have a kind of serendipitous result to them. So one of our staff members actually was a volunteer with the Ringette Association, and she was trying to say, let's analyze our membership for Ringette to determine why, when everyone who participates in Ringette is typically in the East End, do we always get booked in that arena way over there with the star on it? And so it was a very simple project that we did for the Ringette Association. But what the group noticed, because we do have this kind of collaborative environment where people sit around the table and look at different projects, was that there was no participation in the Ringette program in some of the neighborhoods with a lot of children, but in some of the economically disadvantaged neighborhoods. And there are programs out there to help these kids. Now, it may make sense because Ringette's a fairly expensive sport to play in, but it tweaked people to ask the questions about enrollment in soccer as well, and other sports. So we looked at soccer, we looked at memberships at the public library, we looked at a number of different programs and activities for children, and found there were a number of neighborhoods where there was no participation in these activities, but yet there was a number of children there. And so now the different organizations are actually visiting specific neighborhoods to inform them of programs that can help get these kids involved in a number of different programs in the community. So it had a real tangible effect on how they were rolling out their services. Another example here is with Algoma Public Health and their restaurant inspectors. Based on the size of the restaurant and I guess the volume of business determines the number of times a restaurant is visited. And there always used to be some arguments about who visited where and how far they had to drive and how many restaurants they had to do. And so using the GIS, we were able to take those factors and divide the city up into 6 zones for the 6 restaurant inspectors that we have in the community. So it provided them with a system, and I guess now nobody questions it because the GIS system figured it out. So there was some logic there, they think, behind this system. We've also done work in terms of water sample results, looking at whether the municipal infrastructure should be brought out to service a neighborhood, and we were looking at E. coli results that were found in these wells. Another great example is West Nile virus, and so we've been working with Algoma Public Health since the probably early 2001 timeframe in trying to plot dead birds and also look at the results of the mosquito traps that are out there. So these are the mosquito traps, and the size is the number of mosquitoes that were found. The red is the bad mosquito. And so we've been doing a number of studies over time to look at West Nile virus incidents in the community and the number of West Nile birds that are found. And we're also able to do things like within the GIS system, you could do a bit of a analysis to say, show me all the stagnant bodies of water in the community, show me all the areas where there's a number of elderly people over 70, show me an area where we found lots of West Nile virus birds, and then do areas of concern in the community for West Nile virus. And in fact, what they've shown, or what they've done over time, is when you look at the maps, they've actually taken areas that had a high number of mosquitoes and been able to minimize the number of mosquitoes based on their outreach programs. In one neighborhood, there was a number of garages with tires that were left out back. So they said, you got to get rid of those tires, which were breeding grounds for mosquitoes. So they've seen the effect of some of their work in their community based on the analysis of the GIS maps. Another example that's a bit serendipitous is the Public Utilities Commission. They had someone trip over something in our community and sue them. And so they came to us and said, can you do a map of tripping hazards of our equipment? So because we've got all the data and all their infrastructure, we could say, everything that sticks over the ground or could stick over the ground, let's flag on the map. And we came up with a plotting of potential PUC tripping hazards. And then they actually had students go out and look at each of these sites to determine, could someone trip over this thing? So it's a lot of work for that effort. Now, the neat thing was some of our staff people, I guess, were joining them on one of these little exercises to go out and visit the sites. And one of the things you could trip over was the grates on a submersible transformer vault. So in the 70s time period, there was this idea that we would, dig in the ground and put these transformer vaults underground, which probably isn't a good idea because water accumulates in these transformer vaults, and the vault actually heats the water, and there's lots of organic material in there. And so when our group was visiting these, they saw mosquitoes flying out, and they said, I wonder if the health unit has ever visited these transformer vaults or tested them to see if West Nile virus mosquitoes are, breeding in the vaults. And so they did that, and sure enough, it was a fantastic breeding ground for West Nile virus mosquitoes. And now they go out and larvicide those transformer vaults. And we've had some articles published in different GIS magazines about this, and we've had emails from people in Ohio and around the world that have said, wow, from that article, we've gone out and investigated some of our infrastructure and found a similar thing. And I guess they don't do this anymore. They figured out that putting electrical equipment in the ground, in water, is probably not the best idea. So it's not a problem anymore, but this infrastructure still exists in a number of communities. But as an example of having the different, having kind of that centralized GIS body that's doing this work that has the knowledge of the PUC plus the knowledge of working with the Algoma Public Health Unit, we're able to tie those two threads together and come up with some interesting solutions and address some issues in the community. They also do things like, because we've got the locations of all the pools in the community, they send out mailers specifically to people with pools to say, don't forget to empty your pool cover early so we don't have any mosquitoes breeding in those pool covers. Another example, and I'm going to go through a number of examples here, hopefully won't overload you, but really the idea, I think, is to give you an idea of how GIS can be used in this environment. And usually when we give these presentations, we have about 40 or 50 other ideas where people think, oh, could we do this and that with our data? So hopefully it will stimulate some discussion. One of these projects, or one of the projects we did with Sault Area Hospital and Algoma Public Health, was looking at childhood injuries and visits to the emergency room. So these are children ages 0 to 5. And what they found was there was about 90% of the ER visits came from 3 neighborhoods in the community. And those 3 neighborhoods are close to or within some of the socially assisted neighborhood developments. And so now they're able to go in and take a look at that and say, is there adequate play infrastructure for these children in these neighborhoods? Or is there education programs that we need to run in these neighborhoods? So it helped them, again, to better understand and focus their activities in the community. They also looked at doing an analysis of the costs of these ER visits. And so helping to justify investing in some of these areas to help improve the infrastructure for the children. Now, another example that we recently completed was a simple example, really, but was with the eHealth office in Northern Ontario, which is a partnership with the Northeast and Northwest LHIN. And they did a survey of the ICT needs of the Northern Ontario LHINs. And so their vast geographic areas is about 80% of the landmass of Ontario and between the 2 LHINs. And so they surveyed all the healthcare providers, the CCACs, hospitals, health units, physicians, pharmacies, a really comprehensive survey. And when they got this data back, or I guess just before that, what they were hoping was that the survey would enable them to prepare the Northern Ontario eHealth office to implement the strategies for their ICT tactical plan. And so they inventoried current technology, assessed the project management level, the resources there, a number of different factors, privacy policies, and then we helped them to plot this information in a way that was a bit more understandable in the report. And so this one was looking at the people that were interested in a regional approach to information and communication technology, the operating systems that were being used across Northern Ontario. Another example is organizations with a privacy and security policy. So no is red, so it's a little surprising to see in some areas the number of no's for the presence of a privacy and security policy. Another project that we were involved with was with a partner, a company called Infonaut that's in Toronto. And Infonaut developed with the Ministry of Health a community health atlas. And so what you could do on this community health atlas is drill in by LHIN or looking at the entire province. And you could check off different indicators on this community health atlas, and you could light up the map in different colors. So regions that had higher incidences of diabetes or heart disease or whatever would light up the different areas of the map. So this was really interesting information. One of the challenges for, I think, all the LHINs, but especially in Northern Ontario, given our land mass, was that when our stakeholders logged into the system and they said, show me the incidence of diabetes, our region, the entire Northeast LHIN there, would light up, in a dark red color, says you got lots of diabetes. But it didn't help the stakeholder in Sault Ste. Marie to understand, is that a problem in my community? Or are there other communities with really high percentages that are dragging that average up? And so we did a pilot project to look at augmenting this health atlas to have a community-level health atlas so that people could actually drill in and look at indicators within a community, their community. And we did a pilot with Sault Ste. Marie based on some of the data that we had and in collaboration with the Ministry of Health. And so it was an interesting project, and I think has great potential in the future as well to help the LHIN planners better understand the needs of the communities in their LHIN and also perhaps direct resources based on the needs of their communities. We've also done some examples of retirement home evacuation plans using the GIS. A recent example was the lead water issue. As you're probably all aware, there was lead water testing. I believe London was the first community that identified a problem. In Sault Ste. Marie, because we had the GIS system, we were able to, rather than just do some randomized testings of homes for the presence of lead in water, we actually could go in and select homes based on lead service leads to the home. And the other thing was that when our GIS group started to do the research, what they found was there was a typical time period, I think it was 1942 to 45 or 47, where lead was used more predominantly for these leads. And I guess they did more research, and it was partly due to the war effort and copper being in short supply. So they were able to then also query the database to say, okay, these are the priority homes to be tested in our community based on either the presence of a lead service lead or the date the home was built. And so we were able to actually identify homes that had lead service leads. And we were also able to do some interesting work with some of our partners to prioritize. So we actually had information on mothers that had recently given birth in the community, to look at testing those homes in priority and letting those people know even in advance that you may have lead in your water and you need to get tested, and we want to let you know right away because you have an infant in your home. And so obviously a priority for them to test their water. No presentation about Northern Ontario would be complete without a bear sightings map. So this is just another simple example we had of reported bear sightings in the community. And over time, again, we've been able to show through education efforts, different areas of the community have gotten rid of their bear problems because they've educated the neighbors about the importance of getting rid of garbage or picking up apples from apple trees or cutting them down, whatever the case may be. And so you can see that neighborhood, essentially the bears migrated to another neighborhood because the residents were taking better care. Now, at this point, I'm going to turn it over to Michelle, and she's going to talk about some interesting projects we've done with Sault Area Hospital in the area of C. difficile, and also some collaborations with other health care organizations across Ontario.
Okay. So C. difficile mapping. In 2006, the Sault Area Hospital encountered a serious C. difficile outbreak, and they engaged us. Sorry, I don't know if my mic's working there. And they engaged us to create an application that helped them to collect their data and also for their investigation. So the type of data that was collected was date of admission, date of onset, date of diagnosis, patient room movements, doctor information, antibiotic treatments. This was what the application looked like, and the inspectors from the Public Health Agency used this application to collect the data. We also mapped the hospital in 3D using orthophotography. Okay. The items mapped included room types, bed locations, doorways, closets, elevators, and stairways. I can give you a representation of what that looked like. This is an example of the floor plan that was laid over the orthophotography, aerial photography, and this was used in the process to map the hospital in 3D. So here you're seeing the rooms, and the colors are different colors are representing the different room types. Okay. So in the analysis, the queries that were executed included how many patients were diagnosed, how many of the diagnosed patients were in each room over a period of time, how many patients were in a room prior to being diagnosed, where was a person transferred after being diagnosed with C. difficile, and there were many more questions that were queried. Okay. As a result of this project, we're now going to, in the next few months, be developing a new product that includes, it's an extension of this project, and we'll be using RFID technology to take patients, assets, and possibly staff, and also use that to query a GIS system. So the benefits are to save money, improve patient safety, and help save lives, increase operational capacity and efficiency, performance, and accountability reporting. Another project we're involved in is with the KLNA Public Health Unit. Here we mapped the Kingston General Hospital in 3D. and also created an application to track absenteeism within the hospital due to illness. So here you're seeing the percentage of absenteeism due to respiratory illnesses. And these are the different levels of the hospital and departments. So you're seeing here one of the departments where there have been a high rate of absentees. Here you're seeing the percentage of absenteeism due to gastrointestinal illness. Another very exciting project that we're involved in with many partners, as you can see, it's a GeoConnections project. The KFL&A Health Unit is the leader of this project, and it's a project named Geospatial Emergency Department Syndromic Surveillance. And what we're doing here is helping to map respiratory and gastrointestinal hospital visit data. So the project team is undertaking this project and primarily to educate health professionals and also other members of the community about emergency department cases for respiratory and gastrointestinal illnesses. So this information is going to be available on the web for the public and also other health professionals as part of the project. So the objectives of the project are to limit the spread of disease, reduce the impact on hospital emergency departments, save lives among at-risk populations, better understand the spread of disease. Here's an example mock-up of what the site potentially is going to look at. If you see on the right-hand side, there's a Maps tab that will be made available. And once you click on the Maps tab, you'll be able to see the information of cases, gastrointestinal and respiratory cases by the different areas within the Kingston area. So there'll be 15 hospitals that are involved in this project. Okay. So that said, I'll pass it back over to Tom to give the final few slides.
Thanks, Michelle. I think we split that up 50-50, but I talked a lot longer than Michelle. Some of the GIS and health benefits that we've seen, hopefully were evident from some of the work that we've shown, is that GIS helps form a common pool for more multi-organizational data. And obviously you have to be careful in terms of privacy, but we found that properly anonymizing the data, and we've had conversations with the Privacy Commissioner's Office and numerous privacy lawyers, et cetera, can really help to pull organizations together and help them collaborate. It also has been a fantastic tool for visualization of data in general. It's helped to optimize service delivery of the organizations in terms of caseload distribution, selective mailouts, determining where they should open up offices and service locations, reduce liabilities when you're looking at the projects like C. difficile, tracking of change over time to see how your programs are having an effect on the community, and also some determinations of cause and effect. And this is probably the early stages for this area, but I think there's a lot of potential for research work to be done utilizing the GIS platforms. Some key success factors that we found, certainly in Sault Ste. Marie, the initial system was mandated from the top down, and there was support for the initiative and really helped us to acquire that base data for the community and help ensure that we had the support to have multiple organizations contributing and participating in one solution. There was also a benefit that we've seen by being a neutral third party. We're a nonprofit organization that works with all the agencies so that, in other communities, I know the municipality has tried to roll out similar systems, but there's often a tug in terms of resources when someone's got a priority, but the city has their priority, everything else kind of slides. And so by having this kind of neutral third-party organization in the middle, we've been able to work with all the organizations collaboratively and help set priorities amongst these groups. Also, a strong emphasis on privacy and security is critical. We've engaged multiple stakeholders. I think part of the momentum that we're starting to see in Sault Ste. Marie is a tribute to the GIS team we have in Sault Ste. Marie and the countless presentations they've made across the community to different organizations to get people excited about GIS, see the potential of GIS, and start working with them on projects. And that ties into certainly the staff. We've got a really talented staff there in Sault Ste. Marie. Some of them have really developed the skills and are extremely knowledgeable in this emerging area of healthcare and GIS. And so that certainly helped us to grow this implementation. And so we're looking forward to doing more, working with more organizations. As Michelle mentioned, we're starting to do more work across the province. And we've been collaborating with the folks here at the University of Waterloo and Dr. Safavi Nayeni. We're hoping to get some research projects going in terms of RFID and sensor-based solutions tied into GIS in healthcare environments, looking at disease outbreak. So there's a tremendous amount of work that can be done in this area, and a lot of promise I think the technology shows. Obviously, it's not a solution for everything, but certainly we've seen benefits, intangible benefits in our community from utilizing GIS in this area. So with that, I think we're all finished. I want to thank everyone for attending today, and if anyone has any questions, I guess we'll get underway.
So I have an opportunity for everyone to, if you have questions or comments or you want to bring to the table, we'd welcome those. I'll start that off by, just put your hand up, we'll get a microphone to you. Where were the challenges in doing this? I mean, you started right, it seems, by getting your mandate, but when were the points where you wanted to scream and it wasn't it was difficult?
Yeah, I think talking to some of our GIS staff, a lot of the screen points came in terms of the data and scrubbing the data, cleaning the data, making sure people understood the importance of collecting the data completely, all the forms filled, et cetera, in order to really do analysis on that work. And that also led, I think, to some work that we did in terms of, just standardizing some of the forms that the healthcare organizations had. Also creating little applications that had drop-down menus for street names and postal codes and that kind of thing. So you didn't have, Chestnut Street spelled with 2 T's and 1 T and all that kind of stuff. So a lot of it really stems around the data that was input into the system.
And the other sort of mundane side of this is number of people and where you got your funding. Right.
The initial funding came from the municipality, obviously, the Public Utilities Commission, and also we had some funding from some of the Northern Ontario development groups, FedNor and the Northern Ontario Heritage Fund, as well as in the, I guess it was early 2000 timeframe, there were some programs the provincial government had called GeoSmart, and so there were some projects that went on around the Sault Ste. Marie area that leveraged that GeoSmart funding. And certainly more recently we've seen some projects with GeoConnections funding.
So how many people are actually behind this then?
We have a staff of 14 in our Community Geomatics Centre, as well as, there's always some interns and students that are involved in this as well. We've certainly tried to, do outreach with our local university, our community college, to get as many students as we can interested and involved in GIS, because certainly there's a demand out there that we've seen in Northern Ontario, and I know talking to other colleagues across Ontario, there's certainly a demand for people who have GIS skills.
Questions, and make sure we give people.
How available are three-dimensional GIS data for buildings or for three-dimensional type of object that you want to include in your application or software? Because I assume that for that hospital, you also generated that, right? Or that's
right. We generated that data, and we really obtained that information. In the case of Sault Area Hospital, from their architectural drawings. It's an older hospital. We are building a new one right now, but it was an older building, so we actually had to pull out the old, paper-based drawings.
If you actually want to create the same type of model for other hospitals, should you do it also for there actually companies who can do that for us, or are there agencies that have this data? What's the status of the availability of this data?
Yeah, not that we found. I don't know if anybody else knows of one, but we haven't found one. What we've had to do is, with each hospital, get that data directly from them in order to build the models.
I see. Okay.
There are people that I've seen a company that walks around with devices and digitizes points as they walk around, and then I gather what they do is relate that to the floor plan for the organization. So there are sort of like professional consultant or engineering organizations that provide that. I don't know the exact technology they use, though, to do it. But you'd have to pay for that, presumably. I guess that's particularly if we want to move into the institution, and this we call micro GIS, that's going to have to be a problem solved because there are hundreds of hospitals, and that's an undertaking for every single hospital. But getting that information could be quite important. And a number of you here, by the way, have I'm sure been involved in GIS. Are there any lessons that, from your vantage point, that need to be considered in things like this? So if you have comments too, welcome that. The other question I wanted to ask you is, I was very impressed by the previous presentation when you talked about you were able to, for example, look at putting signage into particular areas like where there was a known smoking problem. So it dramatically reduced the cost of reaching the population of interest. Can you talk a little bit about the specific thing like that? And then the other is that, have you looked at, if you do these things, and has there been enough time yet that you can see if it changes things over time? In other words, is there any outcome kind of assessment done or planned?
Right. The outcome assessment, the only one we've really done, I think, with enough timeline has been the West Nile, and we've certainly seen some benefits there for the activities that the Algoma Public Health has done in regards to the mapping. The specific example with the signage, we did some analysis for Algoma Public Health in concert with the police department, I believe it was, that looked at drinking and driving and locations of people that were charged with impaired driving, and actually there were certain neighborhoods that had higher incidences of that. So they actually put up signs in these neighborhoods going into, major kind of entry points to these neighborhoods, alerting them about the, the dangers of drinking and driving. And in the schools as well, the schools were mandated to put up signs about no smoking environments, and using the GIS, we're able to pick out, the exact locations of where these different signs should go so that, there was maximum exposure for the different school zones in that area. And I think, with the slides, we kind of culled out, we've probably got thousands of slides and thousands of examples of how it's been used. So there's lots more, I think, where that came from, but you got a taste today of the number of different applications we can use.
Tom, one of the things that has happened here is you have a not-for-profit corporation running a utility, in effect, for at least 2 community organizations, many more. This is a very unusual situation. For instance, in our area, we have 4 GIS systems. The City of Toronto has at least 13, even though they're now amalgamated, and they're trying to bring them together. Now, you may have been lucky in the sense that perhaps by not having, I suspect by not having a lot of money, it forced cooperation. I don't know, but I wonder if you could just comment on the process that you went through a little bit.
Sure, and it's a good point. I think that it was what we've seen in a lot of cases in Northern Ontario is the necessity drives some of these collaborations, but certainly in Sault Ste. Marie, with the municipality and the PUC both looking at implementing at that initial stage, that helped to drive it because they're both kind of at the same point. What we also do within our nonprofit, the Community Geomatics Centre, is that the different organizations all contribute to the upkeep and the maintenance of the system. And some organizations come on board, and really some of them it's a matter of how much can you afford to contribute when we're talking about United Way or the Sault Ste. Marie Public Library. But in other cases, other organizations have come in with a very minimal contribution, but then quickly implemented more and more GIS projects, and so they are contributing more and more to actually if you will, purchase some of the staff time, as well as everybody pays a fee to help maintain the system as a whole. The bulk of the costs are maintained by the municipality and the Public Utilities Commission, but as we bring in each new partner, it's helping to contribute to the solution as a whole, and also helping us to hire new staff so that we can accomplish all these great projects that everybody has in mind.
Tom, Fred Nagari, Centre of Community Mapping here in Waterloo. Have you explored using web mapping to capture fine-scale information with attributes?
On the input side?
Yes.
We haven't yet. Actually, we were talking earlier today with Don about some of the work. We haven't done that on our end. So far, most of the data for our system has been served up through our Community Geomatics Centre. Now, users provide input or provide data to us that we implement in the system, but we haven't used a whole lot of data yet to have them kind of update the system. Usually they just give us a cut of the data, send us an electronic file, and then we'll input that into the system.
I'd like to talk to you more about that.
Sure.
We've had an opportunity to begin collaboration with you over the time. I mean, do you have an interest in, for example, working with people at the University of Waterloo in other areas beyond this? Like, I know we have a very strong smoking cessation presence here. We've got our environmental studies group. We've got a whole bunch of. What is your interest in collaboration with the university?
Hi, interest in collaboration. Yeah, we're really looking forward to taking this initial work that we've done. As you see, I think we're really scratching the surface here in terms of how GIS can be used, and so we'd be really open to working with people on research projects or on other GIS initiatives. We've had obviously some work done now in Kingston. We're working with some other municipalities in Southern Ontario as well with GIS projects, but certainly we'd like to try and do more and take some of the lessons we've learned and obviously combine it with some of the expertise that exists out there in other institutions.
And by the way, if you're interested in working with Sault Ste. Marie, it's virtually a tourist location to go to. I mean, they're a beautiful town. I've had the chance to go up there, and Northern Ontario is actually quite an interesting place. So it's getting up there is a lot of fun too. So.
And we are trying to recruit. We need to hire some GIS developers right now. So if anybody knows anyone, we're trying to recruit. We'll be actually sending around to everybody that's associated with the Institute a job description or two that is available. Sault Ste. Marie is looking for both bachelor's level and master's, PhD level graduates. So there's a real opportunity here for students. Have you done anything with co-op students yet, by the way? Have you considered that one? We have with our community college, not external, but certainly we're really interested in involving other
So that's another thing we might open is talking with the co-op and career services as a possibility.
Yeah.
Well, any final questions or comments? Okay.
Hi, Tom. I see that you have done a lot of work on data collection and geocoding and creating all these very impressive maps. I'm just wondering, when you try to, for example, in a field of those maps, trying to draw circles on particular locations as to target, for example, health interventions, how confident are you when you try to draw those circles? What I meant is, for a particular map, for instance, childhood injuries, one of those maps you've drawn, there are probably, I can say, over many ways that you can prepare such a map. I can easily prepare over 100 maps on the same topic. And for every map you've drawn, it can give you different kind of information, or you can even draw different circles on them based on that particular map. And in terms of drawing those maps, I want to know, like, what method do you use in preparing those maps? And in addition, if we just based on visualization, how confident would you be able to present the result to the audience? I mean, would you consider using some statistical method as to justify that no matter what scale or what the map units you use, you will come up with the same answer.
Right. Fortunately, I can defer the first question a bit, because typically what we do is we rely on the healthcare professionals we're working with to define those boundaries for us. And actually, there's been, I know in some of the meetings, debate in terms of what's red. What level is actually red so that it looks really like it's a hot spot there. What actually defines what is red and what thresholds do we have there. So with each project, we actually work with the different healthcare stakeholders, and they really set the standards in terms of how the boundaries will be set, what indicates a high number and what doesn't. In terms of the statistical component, the tool we use, the ESRI tool, does have statistical analysis capabilities in there. So in some cases where we've got sufficient sample size, and that is a challenge in smaller communities to get the numbers of people you need for statistically relevant information. In some cases, the group can do that work. In other cases, what they're merely doing is plotting actual cases, and you can only draw a certain amount of conclusions. Again, what we do in our center is work with the researchers or the epidemiologists to provide that visualization tool, and we've relied on them to bring in the statistical rigor or analysis on that data.
Yeah, I don't know if you've come across that in a lot of spatial analysis or in the field of spatial epidemiology, we are using a lot of other functions that GIS can provide, and there are packages that do this kind of spatial statistical analysis that will provide evidence as to what causes the pattern on the map, so that whatever scale you use, we will identify the same causes as what constitutes the map pattern. And these are software that provides analytical methods that are not available in current GIS. Right. But they do provide very useful information because they are based on sound statistical method. And it will be interesting to see, because you have such rich sources of data, and if we go further, a step further to identify, to explain the pattern by statistical method, we will be able to produce very useful findings from all your maps, which is so rich, and it's very useful for health applications.
Yeah, absolutely. It's been interesting. We're kind of getting that intersection now where obviously a number of the public health folks are being trained in GIS and how GIS can be used. And we've been training our GIS technicians. They've enrolled in some courses from the Public Health Agency of Canada to better understand the epidemiological principles and some of the statistical analysis work in the health field that they hadn't been exposed to before. So we're kind of bridging that together, and I think now we're starting to see, we're hitting a sweet spot where people are getting a better understanding, and there's more work and analysis being done in the field. There's been a number of books that have come out recently as well that look at this area, and so it seems that it's really right now. There's a tremendous amount of interest in this area, and a lot of people are now really starting to utilize the GIS technology in this way.
Like a very useful application is doing a spatial regression to analyze, to explain the pattern. That would be very useful.
Yeah, absolutely.
Okay.
The person that asked that question is Professor Jane Law. And Jane, would you talk to us about the course that you're going to be giving in September?
Well, thanks. That's a very good opportunity for me to, because right now I don't know how many students have enrolled yet in my course. It's a GIS and public health course. Basically, I will cover some fundamental concepts of GIS, but there will be a strong emphasis on spatial analysis. So as I said, trying to explain the geographic patterns. So there are different techniques and packages. In addition to GIS package, there will be at least two packages that I will go through that will allow you to do some kind of cluster analysis based on statistics, and also spatial regression, where you can identify the cause of these patterns using statistical method. So if anyone interested in, I'm very happy to have you in my class.
Well, thank you. And I know there are a number of people from our local public health units and the regional governments. And I was just wondering if anybody of those groups would like to share their experiences or trials and tribulations. I know you probably have them, and I would like to certainly give you the opportunity to voice or speak to Tom and Michelle about them. Is there anybody in the audience that wishes to do that? Don't be shy.
Got
Thank you.
It's Ruth Anderson from Region of Waterloo Public Health. I'm most interested when you commented about data cleaning as being one of the screaming points. I think that's a common issue. So what I'm kind of curious about is how did you overcome that? And I'm most interested in, did you have some incentives for people to clean their data, or was cleaning data and the data sets really the responsibility of whoever was working with you?
Yeah. In most cases, it was the responsibility of the agency we were working with. And there was a lot of kind of education and training that went on with our staff to sit down with them, to show them. But yeah, in a lot of cases in the projects we've taken, I think the incentive was getting their research or getting their information into the GIS so they could visualize it. And so the group was kind of saying, until you do this, we can't really do the GIS mapping. And so that helped to speed things up. We did a project that was really interesting as well with the Garden River First Nation outside of Sault Ste. Marie, and they have a wellness center there. And so the director, Pam Nolan, a very visionary lady, was looking at how they could use GIS in their community. And what we found in terms of her data was great, but then when we tried to get some of the base data for the actual First Nation in terms of street names and homes and addresses and all that stuff, that became the challenge. And so again, we had to go back and revisit that and spend more of our time on that data collection piece. And so in that case, they actually hired some students to walk the neighborhoods and gather that information. And so usually that's been the case. It's been a little bit of back and forth with our team, with the people to maybe educate and train them. But the incentive usually is getting the data into the GIS system and being able to take advantage of all the functionality it can provide once they clean it up. And I think we've seen, once people see that their data is being used for a purpose that's tangible, that they can plot progress over time and visualize, that they're more apt to pay attention to the data and take care in inputting it.
A question in the back.
This is a question from the web. What other industries besides healthcare are being targeted for this technology?
Well, certainly, GIS had a lot of its roots in the forestry. In the forestry industry, the mining industry is doing a lot of work in GIS right now. And, I think those are the big ones that have been typically used for GIS: mining, forestry, municipalities, and utilities infrastructure.
Hi, I'm Poppy DeMoles-Graham. I'm an epidemiologist with Region of Waterloo Public Health. Ruth and I are actually both epidemiologists there. And I apologize if I missed this, but have you collaborated with any other public health units across the province?
We've started with Kingston. That's the first one. And I think that's it, actually. Yeah, Algoma Public Health. And then the district organization, I guess Algoma covers our district. So, yeah, it's really Algoma Public Health and Kingston Frontenac have been the two that we've collaborated with. We've had discussions with a number of different people about potential projects, but nothing happening right now. We welcome collaboration.
So in what way did you collaborate with Kingston?
With Kingston, it's mainly been the initial project with the hospital where we looked at the staff absenteeism for GI and respiratory illness, and then the new GDSS solution, which is the syndromic surveillance. They've been doing some really interesting work. Dr. Kieran Moore there analyzing, they were looking at telehealth calls as a predictor for upcoming illnesses. And they've been doing this syndromic surveillance solution based on a RODS application that was built, I believe, at Carnegie Mellon University. They've been doing syndromic surveillance and analyzing to try and look for patterns to determine any outbreaks. So that's the interaction we've had with KFLNA right now.
So do you have any particular interests that you'd like to collaborate with other public health units on?
Yeah, I think, we've had a number of discussions with our health unit, and there's certainly been a lot of different ideas. One of the ones that seems to be getting a lot of traction is looking at flu immunizations and the flu shots and the percentage of people that are, taking the flu shot and neighborhoods that are or aren't. And so we thought that may be a good project to start. It's not terribly sensitive data to work with as a way to demonstrate something maybe that could be done across the province to do analysis. I mean, that's just one idea.
What about you guys?
We have a lot of projects on the go, West Nile virus being one of them.
Yeah.
We've actually met with Jane Law, so we are considering collaborating with the University of Waterloo, but I want to be clear on what your interests were, and you had mentioned flu immunizations, and that's one area.
Sure, we have done West Nile virus. I mean, I guess fair to say we would be open to sitting down and maybe having a brainstorming session, because I think there's a number of areas. Our real interest is how can we utilize this GIS technology in more ways to help the public health and hospital system.
Another question from the web. Can you elaborate on any privacy issues that have come up?
Touch wood, we haven't had any serious privacy problems, mainly because I think from the outset that's been something that's been understood that we have to take great care in. And so, again, most of the data that we've dealt with has been anonymized data. We don't receive any name, address information for the health information that we're working with. And so in that perspective, we typically ask organizations, just give us, anonymized data. And then I think in terms of issues, what we've tried to do is, certainly we've worked with the Privacy Commissioner's Office of Ontario, and we work with Robert Solomon, who's at the University of Western Ontario, to help do training for our staff and the organizations that we've been working with related to privacy. As well, we've applied for and hopefully will receive a grant to do some research into GIS and healthcare environment through a program that the Privacy Commissioner's Office of Canada has. And so there is a fair bit of literature out there, I think. There's been a few books written related to how to lie with maps and GIS and health and privacy issues. So we've tried to adopt those best practices where we can.
Just one comment I'd make is that GIS is primarily a visualization technology, and I think and Jane, you can correct me if I'm wrong about this, is what you're talking about is a combination between data mining, where you get the relationships, for example, and causal factors with the visualization technology. And then a quick question on that is, do you have any expertise currently in data mining, where you're looking for patterns in the data that you may then use GIS as a way of visualizing those patterns, which gives you the underlying causalities and things like that?
Right. We don't have, some of our staff has worked with the statistical tools and did some training in their university days in that area. In terms of deep mining, I don't think we have expertise in that area right now. So that's certainly an area of collaboration, I think.
It's an area of great strength here, and we're actually have a project underway with the University of Western Ontario. So there are people who are very involved in data mining, and many different methodologies, and also in other methods of visualization, particularly of very wide data sets, high dimensional data sets. So that's another area of possibility.
Yeah, and I think the maturity of the platform as well, that there are bridges now being built between the GIS solutions and the statistical packages like SAS and some of the other programs. And now the companies have actually developed bridges to help bring in a lot of that statistical rigor into the GIS world.
The other thing I mentioned, Jane, because
I just want to briefly mention that data mining, when we use data mining tools for example, cluster analysis, the difference with here when we use GIS spatial data is that we have to modify the model to add some kind of spatial components in the model and to take into account spatial autocorrelation. And that's something that usually we use a different package. For example, a lot of us traditional statistical package you do similar things like regression or cluster analysis, but not with that spatial component. So we're talking about that's why we apply spatial statistics for this kind of spatial data analysis.
A lot of work presented is based on primary data. Has population, be it census data or survey data, been used for similar kinds of analysis?
We have purchased Stats Canada data, and we have a large library of the demographic information contained by Stats Canada and the information they have in our database that we have used for analysis in our system. And there is a group of communities I know that have come together as well that we're a part of that are licensing larger pieces of data, I guess, from Stats Canada and now integrating that into the GIS system.
Yet another question. What is the cost involved for a public health unit for a collaboration project?
Really depends on the size of the project, the amount of data that we'll be working with, the amount of data time it takes to scrub that data and put the maps together. So it's varied, from $500 to large projects in the tens of thousands of dollars.
I just wanted to follow up about the privacy question. If I understood correctly, you had mentioned like a couple of instances where there'd been targeted mailings based on findings from some of the GIS, like the lead in homes or people's pools and stuff like that. I'm wondering if you can comment about the privacy concerns about that. Like, on one hand, I could see that being potentially useful for me as a homeowner, that I've got a lead service pipe. On the other hand, I find it really, really creepy that somebody, I don't even know is saying like, hey, we know this about you, and I was wondering if you could comment a bit more about that. And who is involved with, with sending out that information? Like, who ends up getting their hands on, some of that sensitive information that ends up having to be sent out in the first place? Yeah, typically the custodian of the data, whoever that may be, would be the one that would be sending out the information. So, or the organization that's in charge of coordinating that effort. So it's Algoma Public Health, sending out pool cover notices. Then it would utilize data from the municipal system, but Algoma Public Health would be sending out that notice. And oftentimes for those mailings, it would be resident. It's not a name, it's a resident, and it goes to everyone in that postal code. So it's interesting, and certainly some people have that feeling about the data in terms of, wow, they've got a lot of information. But it's funny in that when you look at the other industries out there, insurance or banking or the other ones, I mean, we're just scratching the surface in terms of the profiling those organizations do on individuals in terms of their buying habits and all the rest of it. So doesn't make it right, but certainly we're sensitive too, I think, and this is where the organizations we've worked with have been very careful to look at which projects we're undertaking, what information, how we're using this data. As our organization, we haven't worked with private sector companies to sell services to people. It's always been kind of approved through the group in terms of what projects would be undertaken that actually contacted people in different instances. Okay. One other question. I was just also curious about decision making and public participation in decision making, and your use of these tools to facilitate collaboration and decision making among multiple partners, and what your role is to facilitate some of that process. By you provide some of the analysis, and then are you kind of acting as a consultant and facilitator, or do you just kind of give it to them and then it's up to them to do whatever they want with that as they wish, or how does that happen?
Yeah, within the I guess the Geomatics Centre environment, so there is a stakeholder committee that's really the members that are contributing that come together. So there's that takes place, and then in most cases our analysis or input typically focuses on the technical or GIS aspects. The conclusions or the research would then fall to the different organizations to do, take any actions that they see or any further research that they want to have done based on the conclusions that we provide them or the analysis we give through the GIS. I think in almost every project, like probably any research project, every time you do one, it just raises up 40 more questions, and then you have to go away and do more work into it. So it's kind of that collaborative, iterative process that we've seen in most of our projects.
The question was, have you ever tested RIF being tested by Cancer Care Ontario? Now, I have the advantage of access to Google here, and I looked up Cancer Care Ontario RIF, and it came up with the Rapid Inquiry Facility. So I don't know if that's what they were talking about, but my guess is probably yes.
Yeah, safe answer is no. I don't believe we've done any work there.
Does anyone know what that is about? Did you guys know what that's about? Do you want to just say a few words about it so people know about it?
I can't say too many words about it. I suspect the message might have come from Eric Holowati. Oh, okay. So they have a center there that they're working on and doing some interesting things. And anybody that's interested should Google it and take a look. They're linking their cancer incidence data and looking at the geospatial analysis of that.
Any final comments or questions? If not, Tom and Michelle, thank you very much. A very interesting presentation. Look forward to talking to you in the future. Thank you.
Thank you.
So I'd just like to wrap up today's seminar, and I thank our speakers and the very energetic discussion by our audience, both here and coming in virtually. Thank you for all of your questions. It makes it such a much more enjoyable experience for us all when you bring your comments and your questions with you. So on behalf of the Institute and the University of Waterloo, thank you to our speakers. I've got a small gift was a token of our appreciation. That's Michelle's. It says so on the box anyway. And that's yours. So thank you very much. And I look forward to everyone coming back again for our last seminar for the winter, I guess, spring season on June the 25th with Dr. Danny Sands of Cisco Systems and Harvard Medical School. So come back on the 25th and we'll have another great time. So see you in June.